The presentation today is going to be on HPV primary screening for cervical cancer prevention. And by way of disclosure, I am a consultant and a speaker to Roche Diagnostics. I also work with a number of other diagnostic companies. I work with Becton Dickerson. I'm a consultant to Beekman Coulter and other companies, all of which are developing cervical cancer diagnostics. So I've had a lot of involvement in the development of different HPV tests. These are the objectives for today's course. We're going to explain the limitations of using cervical cytology alone for cervical cancer screening. We're going to identify key studies documenting the clinical benefits of using HPV for testing. We're going to show how primary screening can be utilized for cervical cancer screening. And I want to update you all a little bit on what's occurring globally. And this afternoon, Eduardo is going to give you a lecture about HPV primary screening, which is going to address all the limitations of HPV primary, which he hears from different people, or the concerns about it. Let's talk about cervical cytology. Cervical cytology has been around now for almost 100 years, and it's been very successful. Everybody, I think, is aware of the history. It was introduced by Babes and Papanicolaou. No one ever talks about poor Babes. He was a Romanian. We talk about the Pap test. We don't talk about the Babes test. It just never made it into the lexicon of cervical cancer screening. Cytology has become utilized globally. And everywhere that cervical cytology has been implemented in a national program with a call and recall system, or in a program where it's widely utilized, we have seen dramatic reductions in cervical cancer, about 75%. The purpose of my talk today is not to explain why cytology has failed, but to talk about how HPV can actually improve over and above what has occurred with cytology in most countries. There are clear limitations, and we have known these limitations for several decades now to cervical cytology. First off, it's very subjective, and it has a low reproducibility rate. That means that both the abnormal rate and the sensitivity of cytology is going to vary dramatically between different laboratories. I was lucky enough to be one of the lead investigators in the Roche Athena trial. And a lot of the data that I'm going to show you comes from that trial. We had a cohort of 42,000 women enrolled throughout the United States who were 25 years and older. These were women undergoing routine screening. We did multiple HPV tests. We did 3 different HPV tests in these women. We did liquid-based cytology using ThinPrep, and we did colposcopy on any woman who was positive by any of the HPV tests who were cytology, ascus, or greater, as well as a random subset of women who were negative on both HPV and cytology. And we did that because we felt you could not assume that every woman with high-grade disease would be positive on either the Pap or the HPV test. So this let us identify cervical disease negative for both HPV and Pap. It was a very well-controlled trial, and it was done as an FDA registrational trial, so good controls. All of the liquid-based cytology in the Athena trial was read in 4 different laboratories. Now, we did not randomize the women to having their Paps read in the 4 different labs, but it was done on a regional basis. The first thing which is important is when you look at the median age of women in the trial which were seen at the different laboratories, the median age was actually about the same. And I think all of you as colposcopists know that a major driver for the rate of cytological abnormalities will be the age of the patient. Younger patients would have higher rates of cytologic abnormalities than older patients, and finding that the median age suggests that we should see the same rate of cytologic abnormalities across the 4 different laboratories. But notice, in Lab A, the rate of ascus or greater was only 3.8%. In Lab D, it was 9.9%. Over a 2-fold variation in the rate of abnormal PAPs across the different laboratories. Why? It's very subjective cervical cytology. And just to demonstrate how subjective it is, this is a pap smear, and I wish Alex Frenzy was still here, because if Alex was here, I would say, Alex, tell me what this pap shows. And he would look at it and say, okay, there are a couple of enlarged nuclei in here. They're pretty trivial. What's the history? And I'd say she's 55 years old. She's HPV negative. 4 negative PAPs in the last 10 years. Why are you showing me this? This is clearly nothing. Okay. And it would get signed out as negative. Let's take the same PAP. Let's make it a 31-year-old woman. Let's make her HPV positive. She had 1 previous PAP 3 years ago that was called normal. If you gave me this same PAP, I would end up calling it ascus. It's subjective. Context is very important. So the subjectivity leads to large variations in the rate of cytological abnormalities. We also know that PAPs are not as sensitive as we previously thought. When I moved to Columbia 27 years ago, Ralph Richer, who was a very well-known colposcopist and GYN pathologist in New York, was my trainer. He was my head of my division when I moved there. And I asked Ralph, I said, how often does a PAP miss a high-grade lesion? And he said, well, they clearly miss some, but it's not very often. It misses maybe 1%, maybe 2%, but that was back in the early 1990, at a time we didn't have good studies. Today we realize that the sensitivity of cytology, despite the fact that we've moved to liquid-based cytology, despite the fact that we have automatic screeners now and computerized screening prior to the technicians review it, sensitivity really isn't all that great. These are the results from the Athena trial. Sensitivity for SIN2 or greater of the PAPs were read without knowledge of HPV status, ranged from 42% up to 73%. Huge variations. In the study as a whole, what we found was that if we look at SIN3 in cancer, 53.3% of women with SIN3 or cancer had a normal liquid-based cytology, read in an accredited laboratory in the United States. Half of the lesions are missed. You have 2 women in your practice. Both of them have SIN3. You do a PAP on them, and one of them you're going to detect. The other one you're not going to detect. And with current U.S. guidelines, the woman with SIN3 with the normal PAP that we didn't detect, you would have her come back in 3 years. And there is a risk, as I will show you from some studies from Italy, there is a significant risk that after 3 years or 4 or 5 years of follow-up, that SIN3 can progress to invasive cancer. The third key issue is that cytology identifies women with lesions. It doesn't identify those at risk for developing a lesion. And remember, what we try to do with most preventive interventions is to identify individuals at risk. People at low risk get one set of follow-up. People at high risk get another type of follow-up. And cytology clearly has a number of these limitations. When we turn to HPV, there is now global acceptance that the sensitivity of HPV is much better than that of cervical cytology. And there's no question about that. Today, it's widely accepted that 99% or more of SIN3 lesions will be associated with an HPV. 95% of invasive cancers will be associated with HPV, and of the more than 200 HPV genotypes, only 13 are significantly involved in the development of invasive cancer. So we have a limited target of genotypes that we need to look at. This is a list of some of the well-run large studies. They're from around the globe. You can see the number of women. You can see whether or not we're talking about SIN3 or SIN2. We have the Mayran study from Montreal in this list. And notice, in every single study, HPV was significantly more sensitive than cervical cytology. There's just no question that this is the case. We talked about poor reproducibility of cervical cytology. Well, HPV is reproducible. This is the sensitivity of the HPV test in the 4 different labs in the Athena study. Cytology ranged from 42% sensitive to 73%. HPV is the same across every laboratory. It's a molecular test. You put the sample in the machine, you get the result out of the machine, you send it to another laboratory, they're going to get exactly or very close to the same result. So much more objective than cervical cytology. So there is now global acceptance that HPV status can also predict risk of developing disease over at least a decade. And we are getting studies now carried out for 15 years where we are showing that HPV status is a good predictor of risk. And I said one of the problems with cytology is cytology tells me only whether or not a woman has disease today. But HPV tells me what is the risk that this woman will develop disease over the next decade to 15 years. This is risk for either SIN2 plus over on the left-hand side or SIN3 plus that we saw in the Athena study. Now in Athena, any woman who was HPV positive or PAP positive had colposcopy at baseline. All of the biopsies were read blinded to the patient's clinical status, and it went through a pathology review committee. Alex Frenzy was one of the members of the pathology review committee, as was I. Then, at the end of 3 years, we did another colposcopy in any of the women who had colposcopy at baseline. So if they still were in the study and were not lost to follow-up, we got colposcopy done at the end of 3 years. So let's look just at SIN3. The red line shows you the cumulative incidence of SIN3 or cancer in women who had HPV 16 at enrollment into the study. And these are not high-risk women. These are women recruited from the general screening population around the United States. And by the end of 3 years, 25%. 1 out of 4 of women, these are 25 and older, who had HPV-16, had biopsy-confirmed SIN3, expert-read SIN3 or invasive cancer. If you had HPV-18 at enrollment, your risk is significantly less, 10%. So it's actually 11%. So 1 out of 9 individuals who had HPV-18 went ahead to be diagnosed with SIN3 or cancer. But if you had any of the other high-risk genotypes, other than for 16 and for 18, notice your risk is much lower. It's only around 5%. So clearly knowing genotype is very important in terms of predicting future risk and current risk of having disease. Another important point from this graph is look at the black dotted line at the bottom. Those are women who were HPV negative at baseline. They have essentially no risk for being diagnosed with SIN3 over a 3-year period of time. Now, I said HPV had a long-term capacity to predict risk. So this is risk determined very precisely with 2 different colposcopies over a 3-year period of time. But let's look at longer-term risk, not identified quite as precisely as in the Athena study. This is a long-term study done by the National Cancer Institute of the U.S. in Kaiser, Portland, Oregon. They had 20,000 women who they did an HPV test together with cervical cytology. And then they followed these women up through the Kaiser system for up to 15 years. And they did standard of care. If the woman had an abnormal pap, she got colposcopy. But there was no real study protocol involved in the long-term follow-up. But they did follow these women for up to 15 years. And this shows you the risk of developing high-grade disease carried out now for up to 15 years. And the curve looks almost identical to what I showed you from the Athena study. If you've got HPV-16, you've got a 15% risk of being diagnosed with SIN3 or greater over the 10 to 15 year period of time. It's lower than we saw in Athena, but in Athena, remember, every woman got 2 colposcopies, whereas here, these women were just followed out with standard of care. But 16 is very predictive. 18 is also highly predictive of high-grade disease. In the Kaiser study, HPV-31 had risk, which were very close to HPV-18. There's a lot of debate now whether or not we want to genotype for more than just 16 and 18. I think it's going to be a number of years before we have the real answer to that question. But in some studies, 31 shows elevated risk. If you've got a genotype other than 16, 18, 31, your risk is quite low. And again, look at the black dotted line. Even following women out for 15 years, a single HPV being negative shows very good protection against a subsequent diagnosis of SIN3 or cancer. Long-term protection. Move now from the United States. Let's look in Denmark. This is a Danish follow-up study. A smaller cohort, 8,600 women, similar protocol. And in the Denmark study, what they did was follow the women up long-term through the Danish National Registry. Every pap, every abnormal biopsy, all of that information gets recorded into the National Registry in Denmark. So it's a great place to do long-term follow-up studies. bad place to have an STI because everybody can, it gets registered also, but great place to run cervical cancer screening studies. And here you can see the data from Denmark, and this is out through 12 years. Red line's HPV 16, 25% risk of having CIN3 or greater after 12 years. HPV 18 is also quite elevated. Denmark 31 and 33, both showed elevations, but if you had other, you were quite low. And if you were HPV negative, you had almost no risk. So I think you're getting the idea here. Lots of different studies. Clearly, if you're HPV negative, you have long-term protection against developing high-grade disease. If you've got HPV 16, you've got dramatically elevated risk. In this Danish study, if you had HPV 16 at enrollment and then again at 2 years into the study, so you had persistent HPV 16 for 2 years, you had a 1 in 2 chance of having CIN3 or cancer. 50% develop CIN3 or cancer. So clearly 16 is important. 18 is very important because we know it's the second most common genotype found in invasive cervical cancers, so we're really worried about 18. If you've got others, you've got much lower risk, and if you're negative, long-term protection. So let's turn to HPV primary screening. The goal of HPV primary screening is to give you increased sensitivity over cytology, as well as remaining simple. In Canada, you all are not going down the path of co-testing, to my understanding, because hopefully you realize that you do 2 tests and you don't get a lot more benefit than you get from doing HPV alone. The other point, which is frequently not realized when people talk about co-testing, is how complex the algorithms have become. When we first did low-SIL algorithms back in 2001, I kind of did the ASCCP, was part of that team in 2001, they were simple. What do you do if you have low-SIL? Go to colposcopy. Straightforward. Today, the algorithm is a nightmare. You've got low-SIL, HPV positive, low-SIL, HPV negative. Oh, and you have low-SIL, I don't know what the HPV status is. All of this, I have to use my iPhone app in order to figure out how to manage patients. There's a great ASCCP iPhone app. You put in the age, you put in the cytology results, you put in the HPV results, is she pregnant or not, and it gives you the algorithm so you can manage the patient. HPV primary screening, one of the major goals is to get rid of that level of complexity and to try and make it simpler. So let's look at the data for primary screening. I know many of you have seen a lot of this data before, but it's important to see it to really understand it. This is probably the best primary screening randomized trial. It was done in Italy. Women 25 to 60 years of age were randomized 1-to-1 to get either conventional cytology or to get an HPV test. In the previous study, the investigators had already shown that there was absolutely no difference in test performance between a liquid-based cytology and conventional cytology. So they decided to continue with conventional in this randomized trial. Women got colposcopy if the cytology was ascus or greater, or if they were HPV positive in the HPV arm. And the important point on this study is it's like the Athena study. It was prospective, and women had multiple rounds of screening during the study. And so this shows the general outline. conventional cytology arm or HPV testing arm, colpo if you have ascus or greater, colpo if you're high-risk HPV positive, and then they were followed up for 6 years with routine cervical cancer screening, which was conventional cytology. And most of the women had at least one additional screen. Some of them had 2, and a few had 3. So let's look at the data. This is the chart showing all the different potential combinations. Round 1, round 2, total, SYN3 in cancer in the 2 arms. Round 1, twice as many cases of SYN3 were identified at round 1 in the HPV arm as in the cytology arm. And I think all of us would expect that because HPV is clearly more sensitive than cytology. Round 2 of screening, there were 8 cases identified in the HPV arm, and there were 17 cases identified in the PAP arm. Why? You picked up most of the cases in the HPV arm at baseline, so you didn't have cases to be detected during the 2nd or 3rd round of screening. And importantly, at the end of the study, after multiple rounds of screening, the cytology arm never caught up with the HPV arm. For years, those of us who have been advocating using HPV for screening, either as co-testing or as primary, have gotten pushback from the cytology community who has stated it doesn't matter that HPV is more sensitive because I'm going to do the PAP multiple times over a patient's lifetime, and the PAP will catch up over her lifetime. Well, this trial clearly shows you that over a 6-year period of time, cytology does not catch up with HPV in terms of the detection of SYN3. Let's turn to cancer. Equal numbers of cancers were detected at the 1st round of screening. But at the 2nd round of screening, notice there aren't any cancers in the HPV arm, and there were 7 in the cytology arm. And I think that just proves what all of you in this room would know and would predict. If you miss a number of SYN3 lesions and you follow them for up to 6 years, a few of those SYN3 lesions are actually going to progress to invasive cancer. And that's exactly what happened in the Italian study. They saw cancers in the PAP arm, but almost no cancers on the 2nd round of screening in the HPV arm. And at the end of the study, this was a first study to show a significant reduction in invasive cervical cancer using HPV compared to using cervical cytology. And this was a big finding because we had heard from the cytology community for years there is no data that HPV will actually prevent cervical cancer. And this study showed that it does. In fact, because of that result, the Europeans decided to pool the data from 4 randomized cervical cancer screening trials. These were from Sweden, the Netherlands, and the UK, together with the Italian trial I just showed you. It included 176,000 women. It had 1.2 million years of follow-up in these women enrolled in these randomized screening trials, and they clearly showed that HPV testing induces the incidence of invasive cervical cancer compared to cytology alone. And this is a curve from the trials. The red line at the top shows you cumulative detection of invasive cervical cancer over up to 8 years of follow-up in women who were cytology screened. And the blue line shows you women who were randomized to the HPV arm. And beginning about 2.5 years into the trial, you see you start separating out between cancers in the cytology arm versus cancers in the HPV arm. And certainly when you get to screening intervals of 5 years, 4 years, 5 years, you have significant better protection against cancer in the HPV arm than you do in the cytology arm from these multiple trials. So there's no question HPV is more sensitive. There's no question HPV is going to prevent more cancers over cytology. So why isn't everybody doing HPV for primary screening? Well, the problem is the triage of HPV positive women. In these trials, we find that about 1 out of 10 women will be HPV positive. And clearly that's too many women to send for immediate colposcopy. So what we have to do is develop effective triage tests to separate the highest risk group of women who are HPV positive, send those to colposcopy, and be able to follow up the women who are at lower risk because they are triage test negative. And there are a number of different approaches being used globally to look at triage. One is cytology. HPV positive women, you then bring them in and you do cytology and only refer to colpo if they've got an abnormal pap. You can also look at genotyping. Clearly, women who've got HPV 16 need colposcopy, and we send women who've got HPV 18 generally because we're worried about cancers in that population. We've also got P16, and I'm going to show you some data out of the Athena trial using P16 as a triage of HPV positive women. This is the algorithm which we developed for the COBOS HPV test for the FDA approval for primary screening. You screen women. I'm out of place. Sorry. There should have been one slide, but we'll come to it in a second. I moved some slides around. What we were able to do, because Athena was a 3-year study with follow-up of these women, we were able to model out exactly how different screening strategies would work over a complete 3-year period. We knew how many of the women who were HPV positive became HPV negative at 12 months because we followed them up so we could look at spontaneous regression of HPV or clearance. We knew how many women with low-grade disease developed high-grade disease over the 3-year period of time. So we were able to precisely evaluate different screening strategies. And the first one is cytology. Screen women with liquid-based cytology. If they're negative, they go into routine screening. If they're low SIL or high SIL, we do colpo. And if they have ascus, we do reflex HPV testing, which I'm sure is standard in Canada. So how does that work? Well, we would require 45,000 screening tests. We would detect 143 cases of SIN3 or cancer at the baseline screen. And remember, we followed the women up over 3 years, and we would have detected an additional 36 cases of high-grade disease during those 3 years of follow-up. So we would miss 168 women with high-grade disease. You miss almost as many women as you detect using cervical cytology alone. We require 1,900 colposcopies in the whole cohort, and it takes 10.8 colpos to detect a single case of SIN3 plus. So that's the efficiency of the strategy. Let's turn now to something we call the hybrid strategy. The hybrid strategy is cervical cytology for women 25 to 29 years of age. And since in the U.S., the recommended screening for women 30 years and older is co-testing, for the women who were 30 years and older, we would do co-testing with both cytology and HPV testing. Negative on both tests, or if you have ascus and you're HPV negative, you go to routine screening. If you've got ascus and you're HPV positive, or you're greater than ascus, you go to colpo. And if you've got negative cytology and you're HPV positive, we follow you up in 12 months and repeat the co-test. So this is optimal care in the United States. Hybrid strategy, it clearly takes more screening tests because you're going to be doing 2 tests in women over the age of 30, so that jumps to 82,000. The number of high-grade lesions at baseline is exactly the same because remember, HPV positive women with negative cytology don't get identified high-grade disease now. High-grade disease gets identified 12 months from now. And notice, we do pick up a fair number of high-grade lesions. We now go from 36 detected between 1 and 3 years to 97 detected between 1 and 3 years. We still miss 107 women with high-grade disease. Notice the number of colpos jumps by 1/3. It goes to 3,097. That's good for you all as colposcopists. A lot more colpos doing this sort of approach. That was a joke, but nobody laughed. Okay, I'm in Canada, right? I'm not in the U.S. They would have laughed in the U.S. at that. It jumps. The efficiency of colposcopy drops. Rather than taking 10.8 colpos to identify a single case of high-grade disease, it takes 12.9. So it's less efficient. But in the U.S., this really is the baseline. Let's move now to the FDA-approved strategy for primary screening. You test using the Roche Cobas assay. It's the only assay approved in the United States for primary screening. If you've got HPV negative, you go on to routine screening. That is 90% of all women 25 years and older who are enrolled in Athena. If you've got 16 or 18, we send you to immediate colposcopy. High risk, they clearly need colposcopy. And if you're 12 other high-risk positives, what we do is reflex cytology. The cytologists hate this term. You know, reflex HPV is okay. Reflex cytology, no way. But we do reflex cytology. If you're negative, we don't ignore you. We bring you back in 12 months and co-test you. But if you are ascus or greater, we send you to colpo. This is essentially co-testing with genotyping with the fact that in the group who are HPV negative, we don't do cervical cytology. So it's a simple strategy. HPV primary, we're down to 52,000 screening tests. Look at the jump. We detect 197 cases of high-grade disease. We only miss 53, so we miss half as many cases as we do with the hybrid strategy. The number of colpos goes up again, but because there's more high-grade disease, the efficiency of colpo is exactly the same as what we get with the hybrid strategy. Just as efficient, more sensitive, fewer screening tests. So in April 2014, the FDA approved the Cobas HPV test for primary cervical cancer screening. Approval stated that you can begin at age 25. It has a 3-year screening interval. The approval is for the specific algorithm that I just showed you. And the SGO and ASCCP have now developed guidelines for using HPV primary screening. What they recommend is just what the FDA approval said. You can begin at age 25. In 3-year interval is considered reasonable, and they considered the FDA algorithm to be reasonable. And this year, ACOG came out and stated that if you're going to do primary screening, you should use the SGO and the ASCCP algorithms. They added the fact that a woman with a negative history, you should stop it at age 65, and you should not use it if a woman has had a hysterectomy. I think things we all knew with other forms of screening. So there are a number of other issues to consider. Age to start, additional triage approaches, primary interval. Let's look at the intervals. Here you can see in the Athena trial your risk of having high-grade disease if you're PAP negative, HPV negative, and PAP and HPV negative. And notice there's very little additional protection from being co-test negative versus being HPV negative. Move to Kaiser. Kaiser looked at over 1 million women, and they find the same finding. Very little additional protection between being co-test negative and being PAP negative in terms of protection of high-grade disease. If we look at all the different studies, what we show is that HPV compared to co-testing, in every single study, you get a little better protection with co-testing. You use 2 tests, you have to, but it's a minimal amount of increased protection. So in terms of interval, how do we incorporate cytology versus co-testing versus HPV primary? Well, that's simple. If we have co-testing at 5-year interval, and you have 11 cases per 10,000 women, and then we move the interval for HPV primary down to 3, you have actually better protection against subsequent high-grade disease with 3-year primary than with 5-year co-testing. So we adjust for this difference in sensitivity by using a shorter interval. We hear a lot about individuals who have cancer, who are HPV negative, but picked up on cytology. This is a huge discussion in the United States today. This is the best data that we have on that, and it comes from Kaiser. They had 405 women who were detected with cervical cancer at a time they were doing co-testing. And they had a total of 26 women who were HPV negative but were PAP positive. And this is used as an argument in the US that we have to co-test everyone. Well, it turns out when you look at those 26 women, 5 actually had endometrial cancer. They didn't have cervical cancer. 12 had a co-test collected at the same time the cancer was diagnosed, so they had an obvious cancer and they took a co-test. 4 tested HPV subsequently positive before their cancer diagnosis, and there actually were only 3 women who were PAP negative, HPV negative, that clinically mattered. The other cases aren't clinically mattering. An area I think all of you are going to be extremely interested in seeing the data. Women 25 to 29 years of age. If we look at the prevalence of HPV, it's quite high in this age group, 21%. But notice there is less 16 and 18 in women 25 to 29 than there is an abnormal PAP test. The key is looking at SIN3 in this age group because SIN2 is probably going to regress. So let's look at the prevalence of SIN3 in women 25 to 29 and compare it to older women. Both in the Athena study as in the PALM study, a large European screening study, we found as much or more high-grade disease in women 25 to 29 as we found in women over the age of 40. So there's a lot of SIN3 in women 25 to 29 years of age. We also found that the majority of the SIN3 in women 25 to 29 has a negative cytology. 57% of the SIN3 in this age group was missed by cytology. Cytology actually detected more high-grade disease in the older women than in the younger women, which is something I had not expected would take place. Let's turn now to the final biomarker. It's going to take about 2 minutes. It's not going to be long. P16, I know you heard about this morning, is a cyclin-dependent kinase, and it's involved in cell cycle control. Under normal conditions, we are not able to see P16 in the cervical epithelium. But when I have a CIN2 lesion and I do immunostaining with P16, I get very strong signal because it indicates a transforming HPV infection is present. So how can we use this to triage our HPV positive women? Well, we use it simply, combining it with a second biomarker. P16 should only be expressed in cells in cell cycle arrest. Ki67, might be known as MIB by some people, is only expressed in cells undergoing cell cycle progression. So under normal conditions, we should never see a cell expressing P16 and Ki67. If we have that, it's a hallmark of a transforming HPV infection. So we use this in cytology for double staining cells. We take a standard pap test, we double stain it for P16, which is brown, Ki67, which is red, and when I see cells which are expressing both biomarkers, it's a hallmark of a transforming HPV infection. So the concept is simple. We take HPV primary screening algorithm, and instead of reflex cytology, we add dual staining in place of the cytology, and we would send the dual stain positive women on to colposcopy. So these are the results. And now you've had your lunch, you've been sitting here for 45 minutes. Very confusing. HPV status coming across, dual stain positive, dual stain negative, cytology greater than ASCUS, ASCUS, and negative cytology. So I'm not going to ask you to ferret out the results. Let's look at them. These are women who under current guidelines would not require colposcopy. HPV positive with negative cytology, follow up in a year. Risk of SIN3 plus was 6.4%. HPV negative, ASCUS or NILM, we don't send those patients on to colposcopy. Who do we send on to colposcopy? These are the ones not requiring. And if we look at the whole algorithm, what we would find is that HPV positive women who are dual stain negative have very low risk. They would not go at a risk of 8%. HPV 18 positive dual stain negative would not go. 12 other positive would not go, and clearly HPV negatives would not need colposcopy if they're dual stain negative. Notice only HPV negative women who are dual stain positive would be the only dual stain positive group, and that's at 8% referral. Moving now to looking at women requiring colposcopy, all of the dual stain positive women require colposcopy, including 12 other their risk is 13.8. Some of these women are extremely high risk. If you've got 16 and you're dual stain positive, your risk is 1 in 2 of having high-grade disease. So this gives you very good protection. So what we've looked at is screening with cytology, HPV primary screening, as well as all these other issues, interval, screening 25 to 29. I think everybody is still discussing what is the best approach, use of different algorithms, and the use of biomarkers to triage HPV positive women. Thanks a lot.